Hello, I welcome you all, faculty and delegate, in the Hackathon of Heart India Conclave 2021. As you know, Heart India has been founded in 2013. India committed in cardiology, research and education. As you know, Heart India has been founded in 2013. It is a peer-reviewed international journal started in 2013. 32 issues already have been published. More than 300 research papers already published in Heart India, and paper from almost all institutes like PGI, SC, PGI, Jayadeva, UU, and BHU have been published. And paper from Heart India are getting cited lines. And Heart India Conclave has been started in 2015. Last year in purely online mode. This year 7th edition in a row in hybrid mode. And Heart India is using a health camp, which free cardiac camp have been organized in last 5 years. It was halted because of COVID pandemic. And I am proud to share Heart India is sponsoring a study for genetic analysis of cardiomyopathic, idiopathic cardiomyopathy being done in Department of Zoology, BHU Varanasi, and planning for doing more research project studying this part of. Well, it's one day academic brainstorming session of cardiology, and for first session, uh, Singh sir and Dr. Jigyasu Singh, and our first speaker is Dr. P.R. Sinha sir, who is a well-known figure and who have been a pioneer in the field of cardiology. He has done MBBS, MD, and DM from Institute of Medical Sciences, Banaras Hindu University, and he has been the lecturer in the Department of 1997. He has more than 50 research papers to his credit. He has also written one book for the awareness of heart disease in masses. So I request Dr. Jigyasu Singh to introduce Dr. P.R. Sinha sir for his talk and introduce the topic.
Good morning, everyone. So, and a very warm welcome to the all participants and all. So, International Diabetes Day also. So, the today's topic is very good and important topics in today's care of our daily day-to-day care, clinical practice also in heart and heart diseases. So, the first session, which will be started by Dr. who knows no introduction, the famous Dr. P.R. Sinha sir, and the topic assigned to him was resistant hypertension and how to approach that disease. It's a very common problem in our day-to-day clinical practice, and sir will explain how to deal with this clinical alignment which we face in our practice. So over to you, sir.
Thank you and good morning to everyone. And a big thank you to Dr. Alok and congratulations him for the achieving this goal, as well as he is doing a wonderful job. And again, this conference is going to be a very enthusiastic,
Recording
very
in progress.
and very informative to all of us. So I have to share the screen. Can I get the link?
The slides here.
I'm trying my level best. Just a minute.
Share screen.
Yeah, I know that, but anyway. Is it visible? Is the slide visible?
No, sir. Slide will be visible.
Uh, I have shared it, but anyway. Is it visible now? Is the slide visible?
सर स्लाइड विजुअल हो रहा है.
Okay, can I go ahead now? Okay, thank you very much. The topic which has been assigned to me is hypertension, resistant hypertension, how to approach. Okay, at the outset, I must say hypertension is a very common disease nowadays, and it is the leading cause for various disabilities such as the cardiovascular disease, heart attack, angina, stroke, death, and chronic kidney problem, along with eye problems also and the blindness. The recent clinical evidence, that is the SPRINT, has shown that the incremental cardiovascular benefit can be achieved with the aggressive BP lowering. And various guidelines from time to time has shown what should be the treatment target, when you should start the drug therapy. But however, in spite of availability of the guidelines, availability of the very cheap medicines for this, but we achieve to fail the target blood pressure levels, and there are many reasons for that failure, and which can be a trivial issue of just non-adherence of the treatment protocol by the patient, inertia from the doctor, or the complexity of the disease. And they can all result into the patient fall into the group of the resistant hypertension. So is it just a regional problem? No, it is problem everywhere, even in the well-developed, advanced countries such as the America, only the half of the patients are controlled or treated by the prescription, and only 27% are under control. So you can see the enormity of the problem. In spite of knowing everything about the hypertension, the patients are not controlled properly. India is no different. Rather, its a condition is worse. Only 33% and 25% of the urban and rural population respectively have hypertension, and out of which only 38% in the urban and 25% rural receive the treatment. But the target achieved, which is guideline directed for the control of blood pressure, is very abysmal. It is just 1/5 for the urban population and 10% in the rural population. Said that all leads to the not only the uncontrolled but difficult to treat and the resistant hypertension. Further, Sprint has said that you have to lower the target to achieve the best results or to avoid the various complications of the hypertension. And therefore, this has again increased the not only the number of hypertensive patients, but it also increased number of resistant cases. What is globally accepted today in 2021? In an adult population, you should achieve a blood pressure of 140/90 with lifestyle and the medication, that is a 1A indication. And if possible, if the drug is well tolerated, go up to the 130/80, again the 1A indication. But first you have to achieve the target below 140/90. Systolic you have to keep 80, but don't go below 60. And it's preferably, especially for the comorbid conditions such as the diabetes and the renal disease. So what is the resistant hypertension? Failure to achieve the target level of 140/90, or today it is 130/80 in comorbid conditions. When patient is adhering to all the prescribed medicines, then the medicine should be at least 3 medicines for the blood pressure, and in which one should be diuretic. So medicines that one is not able to achieve the target level by 3 medicines, and one of them is a diuretic. It's a simple definition. What are the reasons? Drug-related causes, which can be from the patient or from the physician. Not level of one always by the patient. Medicines. There are unknown causes also there. Then office resistance, psychological causes, secondary hypertension, call it as 5%, can be and from the patient or from the physician, which can interfere with the treatment is always by the patient or the control of the hypertension. So what is the prevalence? Prevalence is 20 to 15% in population based and 15 to 18% in clinical based report. However, in nephrology clinic, the resistant hypertension, so prevalence increases up to
prevalence
50%.
prevalence
So in
is 20
secondary
to
causes, the
15% in population
incidence
base
and prevalence of
15 to
resistant
18% in
hypertension is
clinical
very
base.
high. What
However,
are the
in
factors
nephrology clinic,
responsible for the
the resistant hypertension
It can be from the either side patient
prevalence
or from the
increases up to
physician.
50%.
So
In
if secondary
physician is
causes,
involved,
they
incidence and
often
prevalence of
inaccurately
resistant
measure the
hypertension is very
blood
high.
pressure or don't measure
What are the
properly.
factors
They
responsible for the
prescribe
resistant
costly and
hypertension?
complex
It
drug
can be from
regimen.
the either side
There is an
patient or
inertia
from
of
the
increasing
physician.
the dose
So
because
if
of
the
side effects
physician
or
is
because
involved,
of the increase in
they
the
often inaccurately measure the
or the
blood pressure or don't
increase
measure
in the cost
properly.
of the
They
prescription.
prescribe
Then
costly
patient
and complex
factors,
drug
they are
regimen. There
uneducated.
is an inertia of
They
increasing the dose
they fail
because of
to
side effect or because of the increase in the
think or they fail to
or the
for compliance of the
increase in the
drugs.
cost of the
They are often
prescription.
obese and
In
they don't
patient
follow
factors,
the
they're
non-pharmacological
uneducated.
ways of
They
treating hypertension
they
very
fail
meticulously.
to
Then hypertension is stages
think
in
or they
comorbid
fail to
conditions, and
for
especially
compliance
the
of the
secondary
drugs.
causes
They are often obese
poses
and they don't
much
follow the
hindrance in
non-pharmacological
treating the patient,
ways
and
of
they
treating
increases the
hypertension very
number of
meticulously.
resistant hypertensive
Then
cases. Whenever you are
hypertension is
going to
stages in
start
comorbid
any
condition,
patient
and especially
treatment
the
for any
secondary
hypertensive
causes
patient, these things must be
poses
considered
much hindrance
at the onset
in
itself.
treating the patient, and they increases
How
the
you are going to
number
approach
of
this
resistant
patient?
hypertensive
You have
patient.
to review the
Whenever
diagnosis,
you are going
whether
to
you are
start
correctly
any patient
diagnosing whether this
treatment for
patient
any
falls into the
hypertensive
group of
patient,
resistant
these things
hypertension
must
or
be
not. You
considered
should review the
at the
goals
onset itself.
because in elderly the goals may be
How you
different.
are going to
Below the
approach
60 it
this
may be
patient?
different,
You have
and
to review
above
the
the
diagnosis,
80
whether
years it
you are
may be different.
correctly
Then you
diagnosing
have
whether
to
this patient
prescribe
falls
in
into
a
the group of resistant
say
hypertension or not.
patient in a
You should
similar
review
way.
the goals
You have to
because in elderly the
use
goals may be
multiple
different.
agents,
Below the 60 it may be
especially
different,
in class
and
2 and
above
class
the
3
80 years it may be different.
grade
Then you
class
have
2
to
and class
prescribe
3
in a
patient
stages
in a
of the
similar way.
hypertension. You have to
Then you should know
use
about the what are the
multiple
side effects
agents,
and the cost of the medicine,
especially in class
and
2 and class
always
3
emphasis all the
class 2
time
and class
the
3
lifestyle modification and the
patient
non-pharmacological
stages of the
approach.
hypertension.
Then how to
Then you should
approach
know about
for
the what are the side
establishing
effects
the
and the
true
cost of the
resistance.
medicine,
One
and
has to measure the
always
BP accurately. One has to
emphasis
consider the
all
white
the
coat
time
hypertension.
the
One
lifestyle
has to rule
modification
out pseudo
and the
resistance.
non-pharmacological approach.
And definitely, if the
Then how
patient
to
is resistant
approach
to your
for
treatment, as I mentioned,
establishing the
prevalence
true
increases in
resistance,
nephrology
one has
units,
to measure the
then
BP
consider
accurately.
the
One
secondary
has to
causes
consider the white
for the
coat
correct
hypertension.
diagnosis of
One has to
resistance.
rule out pseudo
So
resistance.
fast
And
diagnosis
definitely,
a
if
big
the patient
challenge
is resistant to your
because
treatment, as
if
I mentioned,
accurately
the prevalence
not measured,
increases in
majority of the
nephrology
patients,
units,
though are
then
controlled, may
consider the
fall into the
secondary
group of
causes for
resistant
the correct
hypertension.
diagnosis of
Then
resistance.
one should measure
So
the blood
fast
pressure
diagnosis a big challenge
accurately.
because
Then
if
before
accurately
diagnosing
not measured,
the
majority of the patient, though are controlled, may
resistant
fall into the
hypertension,
group of
you
resistant
should
hypertension.
take the blood pressure
Then
of
one
clinic
should
as
measure
well as
the
the
blood
out of
pressure
clinic blood pressure.
accurately.
That is the home
Then
BP
before
monitoring and
diagnosing
ambulatory BP monitoring.
the
All the
resistant
guidelines they emphasize
hypertension,
there's a class
you
1A
should
indication
take
that
the
there
blood
should
pressure
the
of
blood pressure should
clinic
be measured
as well as the out
accurately.
of clinic
And for
blood
accurate
pressure. That
blood
is the
pressure
home
measure,
BP
you
monitoring
should
and
wear
ambulatory BP
loose
monitoring.
clothes, no caffeine or tobacco
All
for
the
30 minutes
guidelines they
before. He
emphasize
should
there's
wait
a
for
class
5 to
1A
10 minutes.
indication
No
that there should
anxiety,
the
cuff
blood
size
pressure should be measured accurately,
inflammation
and for
the
accurate
inflation of the
blood pressure
bladder should
measured,
be
he
cuff
should
bladder
wear
should
a
be
loose
proper.
clothes,
The
no
cuff size
caffeine
should
or
be
tobacco 30
you have
minutes
to measure
before.
it
He
in the
should wait
both
for
the
5 to 10 minutes.
and these
No
are trivial
anxiety,
issues in
cuff
the
size
mind of the
should be
physicians, but
good.
it can
Inflammation,
change the blood
the
pressure from 2
inflation of the
millimeters
bladder
up
should
to the
be
15
cuff bladder
millimeters,
should be
and then one
proper.
can land into
The
the
cuff size should be
accurate diagnosis of the resistant hypertension. Similarly, as I mentioned earlier, not only the office BP, you have to take care of the out of office, that is the self-monitoring blood pressure, as well as the ambulatory blood pressure measurement for the diagnosis of hypertension, for the treatment of hypertension, as well as exact diagnosis of true resistance. NICE guideline has very elaborately mentioned about the confirmed resistant hypertension, confirm elevated blood pressure with ambulatory blood pressure monitoring or home blood pressure monitoring, and check for postural hypotension and discuss adherence. This is the simple way of comparing these two. If the patient with this normal blood pressure, either in the office or out the office, he or she is labeled as non-normotensive. If there is a sustained they are called sustained hypertension, and the readings are above the level both in the office and out of the office. Masked hypertension, where the office level is normal, but the home BP or ambulatory blood pressure is high. White coat hypertension is high blood pressure in office and low in the or normal in the out of office. So home and ambulatory BP monitoring is very important for the diagnosing, calibrating the various readings, and for knowing the various risk factors and the prognosis for the patient. Nocturnal dipping, heart rate variability, postural hypertension, apart from the diagnosis of resistant hypertension, they are the various things which can be achieved by the ambulatory or home BP monitoring. When it should be implied, if you are suspecting a white coat hypertension or masked hypertension, if you want to diagnose true resistance, there is excessive variability in the blood pressure. If they want to diagnose hypotension, you want to find a drug resistance or symptoms various suggesting of postural hypotension. Then, apart from accurately BP monitoring, one should always think about the white coat hypertension, because this may give an incorrect diagnosis of true resistance in the office measurement. As I mentioned, white coat hypertension, the blood pressure is high at office but normal at ambulatory blood pressure monitoring or home blood monitoring. It has got a high prevalence, 20 to 30% of the apparently resistant hypertension may be due to high coat hypertension, and white coat hypertension can be found from 21 to 39% patient in the untreated hypertension or the hypertensive population. It has been found that patients who have got a white coat hypertension, they have high LV bars, they have got a diastolic dysfunction, and they have got a poor prognosis as compared to the normotensive patient. So it is not a benign condition which can be written off very easily. Rather, it can be a milder form of the essential hypertension associated, or you can find the pre-hypertension. You should monitor white coat hypertension in the due course, either 6 monthly or 12 monthly. Then how you have to diagnose white coat hypertension, how you see white coat and masked hypertension. As I mentioned, about both the diagnosis, if the blood pressure is high in the office, normal in the home, then go for the ambulatory blood pressure monitoring. And if the ambulatory blood pressure monitoring is normal, then the patient is white coat hypertension, and advise lifestyle modification and annually may monitor the patient. But if the ambulatory blood pressure is high and the office BP is high, then the patient is hypertensive, take care of his illness either by non-pharmacology, with or without pharmacological treatment. Masked hypertension is the reverse. BP is normal at the office and high at the home, and then you have to again monitor with the ABPM. If ABPM is high, then it is a masked hypertension. If it is a normal, you can call it a normal hypertension or elevated hypertension, and advise lifestyle modification. Now the third part is the pseudo resistance. Patient is not having the resistance hypertension, but there are certain conditions that mimic that patient is having resistance hypertension, and various causes is pseudo hypertension. It is a very common in elderly or in octogenarian patient or above the 7th or 8th decade. Then there is a non-adherence, which is almost major chunk which forms the pseudo resistance, and most important, sometimes it is the 50% cause for the resistant hypertension. So before labeling a patient true resistant, you should find out whether patient is adhering to the treatment protocol or not. Then physician inertia can result into inadequate regime. Patient is not at fault, and patient present with a resistant hypertension or uncontrolled hypertension. Then there are certain interfering medicines which causes difficult to control hypertension, the use of various NSAIDs, excessive use of alcohol, caffeine, tobacco, excessive salt intake, drug abuse, cannabis, and oral and contraceptive pills. So you should rule out these causes before labeling a patient true resistance pseudohypertension. Avoid about more because it is because of the stiffness or calcification of the artery. BP cuff is not able to compress the artery properly, and there is a falsely elevated blood pressure is measured. This can be suspected in elderly patient if there is a calcification in the line of the brachial artery or any major artery, or it can be measured accurately or diagnosed by intra-arterial measurement, cumbersome procedure. Then one should always consider secondary causes, and we all know 90% of patients are essential, 10% are secondary. Majority of the chunk form the renovascular disease. So common diseases are renal parenchymal disease, renovascular disease, primary aldosteronism, obese patient manifesting as obstructive sleep apnea, drug or alcohol abuse. So these are the various common causes. Uncommon causes can be pheochromocytoma, Cushing's syndrome, hyper or hypothyroidism, coarctation of aorta, primary hyperparathyroidism, congenital adrenal hyperplasia, and etc. So what are the clues that you are dealing with the secondary cause of the hypertension? Difficult to control, young patient, and they are not properly responding with 2 or 3 medications. How to approach these patients? If a new onset young patient with hypertension, he or she is drug resistant, abrupt onset of hypertension, as I mentioned, young patient, then there is a disproportionate evidence of target organ damage to the hypertension, or patient frequently falls into accelerated or malignant hypertension, then you should suspect that patient is having secondary hypertension, and then you should, apart from the normal investigation, that is the normal blood sugar, urea, creatinine, albumin, echocardiography, X-ray chest, then hemoglobin, sugar, potassium levels. You have to specifically approach these patients as per the suspicion of the cause. Then screen for secondary causes. If positive, then refer the patient to the endocrinologist or the nephrologist or the concerned department. Then, so how to evaluate the resistant hypertension? As I mentioned, 3 drugs, still the BP is not controlled, and in one of them is a diuretic. Always exclude causes of pseudo-resistance, I have already mentioned. Then always exclude secondary hypertension and assess the target organ damage. How can you are going to treat it? After all these exclusion, patient should be always emphasized for the non-pharmacological treatment part, which is equally important, and all has got a 1A indication for the treatment protocol, which patient forgets and physicians don't emphasize properly. This is low salt diet, good sleep. You should monitor your dietary pattern, try to achieve ideal weight, and perform at least 30 minutes of aerobic exercise. Then you should optimize the doses of drug. Please use combination of drugs of fixed dose resistance so the compliance is good, so that patient cannot fall into or the adherence is not a big problem. Then if you have to choose the diuretic properly, you can replace it with chlorothiazide or indapamide. If still the BP is not at target, use the mineralocorticoid receptor antagonist, and still then use beta blocker or alpha channel blockers. So as I mentioned, you should always monitor, emphasize for the non-pharmacological treatment. That is very important when you are trying to diagnose true resistant patients. Similarly, a word about the non-adherence, because this is very important. It is the major cause of the resistant hypertension. So both physician and the patient should be evaluated, educated, and they should be emphasized what is the importance of the treatment. Why should you adhere to your treatment protocol and what can be the outcome if you are not adhering to your treatment protocol. So one should always try to avoid costly medical medicines, difficult regimens to follow, then multiple drug regimes, and you should tell the patient. So these are the various ways by which you can avoid adherence, non-adherence in the patient. And most important, education, which can come from the print media or from the treating physician. Treating physician to try to use only minimum number of pills, and if it is not treated properly, encourage them for the home BP monitoring and always frequent call either by phone or they visit or by WhatsApp. So patient habits should also be monitored simultaneously. They should be discouraged from excessive water and sodium consumption, alcohol, caffeine, or nicotine use, and use of frequent non-steroidal anti-inflammatory drugs, because sometimes the arthritis is common in elderly patients. Suboptimal therapy is also very important. Physicians should know what they are doing. Physician inertia is again an important cause. And if you find in that 4 landmark trials of hypertension, that is life, value, escort, and accomplish, physician inertia was seen in 60% patient, uh, and that resulted in uncontrolled blood pressure and may land up with a true resistance patient. Even in the Spain, in one of the study, it was 75% patient. So physician inertia must be tackled by the physician. Try to use the combination of this. This is the RAS blocker, CCB diuretic, good combination. They should be initiated initially. Then instead of using doubling the dose, one should always try to add another drug, because the evidences are there that adding a new drug is 5 times more effective as compared to doubling the dose. Now, this is the guideline which is proposed. You have to use either dual combination or triple combination. And if it is not controlled, then resistant hypertension, add spironolactone in the dose of 25 to 50. If not controlled, then you can use other diuretic, alpha blockers, beta blockers. But if you are using mineralocorticoid antagonist, always monitor potassium. If it is more than 4.5, avoid spironolactone. Then what should be the checklist? You should recheck for the secondary causes. You should always emphasize for the maximum lifestyle change and adherence of the therapy to the patient. Optimizing and reducing the number of the drugs and the pills in the patient should be emphasized by the physician. And if pharmacological therapy, then renal denervation, which has proven and also sometimes unproven roles also. So in conclusion, resistant hypertension is not a small group. It is important group. It should always be thought, especially if you are dealing with renal diseases or secondary causes. It is, you should always find out what are the reasons for this. Good history taking, physical examination should always be performed. Anti-therapy, antihypertensive therapies should be guided accordingly. You should always search for the secondary causes of the hypertension. You should know the habits of the patient. You should try to find out what are the bad habits and also what are the comorbid conditions, so that one can improve the blood pressure and educate the patient. There should be a good rapport between the patient and the physician, because both are responsible for the treatment. Physician must encourage the patient to remember the disability, what can happen to them, and then they should always emphasize what is the reading which you should achieve always. And if it is, you should always, patients should always be encouraged to measure in the home their blood pressure, though they should always be taught to measure it accurately, because in pandemic we are relying on their measurement. and new fixed dose combination, which has been now emphasized by almost all recent guidelines, must be given to the patient so that new paradigms of disease management that improve adherence, then it will reduce the number of resistant hypertensive patients in the society. Thank you very much.
Thank you so much, sir. It was a very wonderful presentation from your side, and you have clear everything, every aspect of resistant hypertension, sir. This side, Jigyasu, sir. One of my questions, sir, to you is when to start thinking about centrally acting drugs like clonidine or moxidine and alpha blockers, and how to choose between these two drugs or other drugs if the three drugs are used. As you have already mentioned that it is better to use another drug than to increase the dose of the drug. So, and what are the precautions we should keep in mind while adding these two drugs?
Uh, the initial drug should always be either a calcium channel blocker, RAS blocker, plus a diuretic, which can be hydrochlorothiazide, chlorothiazide, or indapamide. This is the guideline directed treatment. If you fail to achieve, then you have to add either beta blocker or a mineralocorticoid, which can be spironolactone. But in nephrology practice, it is very difficult to use this mineralocorticoid because often the patient has got the potassium level of 4.5. Then you have no other choice left. You have to use the alpha blockers or the beta blockers. Problem with or this what you have mentioned about the alpha blocker, sometimes patients are not able to tolerate either of the group, that is the RAS blockade or the CCB, because of the persistent cough or by the severe edema in the lower limb. Then again you have to choose these drugs, because if patient is not able to tolerate these drugs, then you have to switch over to the beta blocker or alpha blocker. So, and precautions, as I have already mentioned, renal profile should always be taken care with alpha blockers and these things. You should always think about the postural hypertension, and you should elderly patient prostatic this ultrasound for prostate enlargement, cancers, etc. You can sometimes there's a cognitive effect with the alpha blocker that can be taken care, especially in the very elderly.
And sir, your role about the centrally acting drugs like clonidine and moxidine, sir. Your experience, sir.
I use it in the difficult patient. I I classify them as rather resistant, difficult to treat patients. Now, resistant is a very strict definition. Three drugs, but sometimes you are handicapped in the practice. You are not able to use, suppose you have used RAS blockade, there is a problem. If you are using calcium channel blocker, though they said that newer cilnidipine, this benidipine, they don't have, but still there is a problem of the edema is there. And sometimes it is a very bothersome edema, especially for females in the evening. So you have to choose these drugs, clonidine. So this is the group where you have to use it. So I have broadly classified as the difficult to treat hypertension. And it also becomes important, even you have to use 4 or 5 drugs in patients of renal disease, renovascular disease, if they cannot afford the angioplasty or renal denervation therapy. So especially in the secondary hypertension, which majority we see in the renal practice or sorry, renal causes for the hypertension, they are definitely sometimes with 4 and 5 drugs. You have to use almost all the drugs.
Thank you so much, sir, for for your explanation. Now we are moving to the next topic, and to introduce the next speaker, we have got Dr. A.K. Singh sir with us. Over to you, sir.
Now, the next topic is revascularization in CAD, how to approach. For this, we have Dr. Rohit Tiwari, who is the senior interventional cardiologist at Nayati Hospital, Mathura. He has done his MBBS and MD from the Udaipur Medical College and has done his DM from the IMS BHU. He was also there in Medanta Hospital, and now he is settled at Mathura in Nayati Hospital. Dr. Rohit Tiwari, please.
Good morning, everyone. Good morning, everyone. My topic is revascularization, how to approach. First of all, I would like to thank Alok for this opportunity and congratulate him. It takes quite an effort in the busy clinical practice to have this academic inclination and his untiring efforts. I've known him since even his pre-DM days. We have had the good fortune of spending time in BHU as students, and I have known him since his student days when he was still pursuing cardiology. So from that to this, I have seen his entire journey, and his passion for academics deserves applause. I would also like to congratulate him for the study which they're funding in BHU. That deserves a thorough applause from everyone. Coming to my topic, although it's now getting how to approach coronary revascularization. As students, we are so much into guidelines and so much into academics and learning about newer techniques and newer technologies. And even once we are done with our initial, DM days, and then trying to learn the art of intervention, that we are taken up by the how to do it. The when to do it is also important. The whether to do it is also important. So as you grow in your clinical practice, you understand that still the foremost thing to decide whom to revascularize, whom not to revascularize. By revascularization, I don't mean medical, that of course everybody has to be done, but which patient merits intervention. Still the most important is clinical history and not anatomy. As we start to think कि coronary angiography से decide होगा, that's not the case. It still is clinical history. So this you start to understand as you grow older in your practice कि हाँ ये this is where which will discern a good clinician from a not so good clinician. And then over a period of time, we've seen various studies have shown us that it is not just treating a angiography. You're not treating an angiography, you're treating a patient. So it is not an anatomical blockage that you have to look at. You have to look at his clinical history, you have to look at the anatomy, and you have to understand the physiology of the coronary stenosis. Trying to integrate physiology into your everyday practice is the whole idea of understanding revascularization. In this, the most commonly used tool today is FFR. FFR has been there for a period now. I have been using FFR since my Medanta days. I understand that it is not so easy to use. I have a vast experience of operating in the highest of hospitals. I have worked for Medanta and Escorts, and I have also the experience of working in the smallest of centers. I have had a rotating practice of going around various places. So I've gone to very small cath labs at very small places and I've done work. So I know the best of both worlds. कि जहाँ कोई resources नहीं है वहाँ कैसे काम करना है और जहाँ resources है वहाँ कैसे काम करना है. FFR still in small second tier and third tier towns is still not used, although I try to use it. It is a little expensive when it comes to that. FFR कैसे expensive हो जाता है वो भी I will show you. But if used properly, it improves outcomes. You will require lesser interventions. It reduces the risk of unnecessary intervention, therefore unnecessary deaths in MI. So there is a effect on death in MI, and it makes total economic sense. We are branded as Luteras, although but the interventional community is been badly hit. And if we and if we show that no, what we mean to do for the patient is the good of the patient, nobody is interested in any extra intervention, then trying to understand and incorporate this in your practice will make you do good for the patient, because this is the era of suits. So if you don't do also, you are liable. So how to be safe and how to do good to the patient, there FFR is important. For example, this lesion, it appears anatomically to be significant, but if we do an FFR, in a lot of cases, we will find that the value is more than 0.8. So you can leave that safely for, it's deferred basically. It's not intervention nahi karna, but you can defer it over a period. Maybe another 2 years, another 3 years. So you can leave it safely on medical therapy. Now, for multi-vessel disease also, so it's not that it is just for PCI, it's for CABG also, it will work. It saves resources, it has incremental value in terms of quality of life index, and if we use FFR, the outcomes also improve. Now, how much of a change do you expect? Most, again, if it's a judicious use of your clinical sense, then जो हम लोग angiography देख के the decision that we take, most cases it will not change even with FFR. So FFR is something like if I use the cricketing analogy, FFR is something like using the third umpire referral. So you use it only judiciously. सब में करने की जरूरत नहीं है, because as we see, only 3 or 5% of patients will change if you are judicious in deciding कि इसकी angioplasty करनी, इसकी नहीं करनी. Even with anatomy, you can decide in a good number of cases. Now, this lesion, the top one, although it appears to be around 80%, FFR was clear. It was 0.58, one stent, and the patient did well. The RCA lesion appears to be tighter than the LAD lesion, yet FFR was good, so you can leave this patient to just medicines. What do the guidelines say, and what about the appropriate use criteria? All the guidelines now are, there is a strong thrust on using, it is the highest class of recommendation, highest level of evidence for stable patients where evidence of ischemia is not available. So as I said, again, clinical decision is the clinical history still is the most important. If your patient is unstable, then you need not go for an FFR. And coming to, it should be considered in multi-vessel disease undergoing PCI, for those undergoing CABG, and for left main, use it alongside IVS. Optimize the stents. Now, when it comes to chronic syndromes, patient has angina, yes. Is there documented evidence of ischemia? If there is, then go for angiography. Multi-vessel disease, yes. A lesion in the intermediate lesions, if FFR is less than 0.8, then we go for this. Or the IWFR, the instantaneous wave fraction, if that is less than 0.89, then we go for an intervention. If there is no documented evidence of ischemia, now this area of ischemia, there is the previous school of thought was that at least 15% of LV should be jeopardized, whether by thallium or this. Now, even there are people who recommend intervention if 10% is at risk. So that is one, a good thallium study will tell you how much of your LV is at jeopardized. So that should also be a consideration when you're deciding on intervention. Now, as I said, clinical presentation. If your patient is unstable, culprit lesion, go for intervention. You do not have to think about FFR if it is an unstable patient. If it is an unstable for the non-culprit lesion, there is no recommendation, go for FFR only if it is significant. If it is less than 0.8, then unstable patient has to be treated. Otherwise, unstable angina patients need not be the non-culprit. The culprit vessel, of course, has to be done. So again, there your clinical presentation and your clinical history becomes important. In a stable angina patient, if it is a severe lesion more than 90%, you need not do a FFR. It is very clear. So no wastage of resources. Go for stenting or CABG as the case may be. There will be some patients in whom, even though as I showed in that RC lesion, even though it appears to be 90%, but still FFR suggests that intervention is not needed. And intermediate lesions, this is a boon. The American criteria, European criteria, both are clear. How much of your practice changes with this? Now, if there is ACS, as I said, in ACS, supposing there were 50% patients of ACS in your total subgroup, as many after having employed these criteria, it is only the non-culprit lesions that will change. So you will find that out of 50% who needed intervention, as many as 45 still need. It is only the non-culprit arteries in ACS that you will not touch. For your stable patients is where a major change, supposing 50% of your patients are stable, you will find that if you use FFR, now this will come down to less than half of that. Only 28% will eventually need intervention. A lot of patients of those who are stable, you can actually leave on medicines. So that's the idea, that if it is stable CAD, you need not unnecessarily intervene. Optimize medical therapy. If despite optimal medical therapy patient is not responding, then go for PCI. So use physiology more and more, and use of physiology should make you think more. It should not make you think less. These are two lesions that I want to show you, and these appear to be very innocuous. This patient has a LAD which I would dismiss, had rest angina. I am showing you different views, and I was very hesitant to do anything. The LAD in this, it's only in this view that it appears a little tight. Most views it doesn't appear tight enough. But this patient had a FFR that was around 0.7 and needed intervention. Similarly, this RCA. So anatomy sometimes it's not always कि हाँ बहुत tight lesion ही हम. It's in these patients also where you have a rest angina, you are not very sure. Patient gives you more gastric symptoms than cardiac symptoms in this patient also. The RCA lesion is very debatable on whether we should intervene. So I did an FFR. FFR was positive, and we intervened in this patient. But then you are sure that you have done what is the right thing to do. Another case example, a 75-year-old had PCI long back in 2005 and 2017. He developed class 3 angina in last 3 months. Stress echo was positive. These slides are somehow not running, but we did, his RCA was perfectly fine. RCA stents were doing fine. It was the left system which showed around 70% lesion in the circumflex and around 80% in the LAD. We did a FFR to both. The FFR in both the lesions was negative. The patient had class 3 angina, as I said. Given his negative FFR values, I told him his symptoms did not appear to be cardiac. Optimized his medicines, added some proton pump inhibitor, and I added a liquid Gelusil also. But he continued to have symptoms. So I referred him to a friend in Medanta because now I don't go to Medanta anymore. After 2 weeks. And now what more can we do? I have already done his FFR. FFR we know. What next can we do? In this patient, there they did a IWFR, the instantaneous wave FFR. That FFR we know. FFR के अपने drawbacks, अपने limitations हैं. If the guide is damping, then you will have a different value. Subtle changes, say you can have changes. The more you use, like any intervention, the more you use this, the more you know the drawbacks of it. In this case, patient, IWFR came to our rescue. A single stent was put, and so IWFR is again like, although most patients who use IWFR versus FFR are more comfortable with FFR. FFR is somehow a little more user friendly. Now use physiology for guidance. We'll see this kind of a lesion very frequently. You have this kind of a LAD. कहाँ पे stent करना चाहिए? 1, 2, 3. There are 3 sites. Where should you put a stent? How many stents should be put? And how to return his blood flow to normal. FFR was done to this segment. When we do a pullback, we know that which is the most significant place. Since this was most significant, we did, sorry, the distal lesion appeared to be significant. The FFR was 0.7 and FFR and pullback in the proximal segment was 0.9. So we decided to stent this. After stenting, the proximal lesion becomes positive. 4 FFR pullbacks, 3 syringes to be changed, 2 wires used, 25 minutes more, and we had to actually do both the proximal and the distal lesions. And similarly in the RCA, this tells us along the length of the disease which place should be stent. I'll show you one artery. Is this artery physiologically significant? Where should I stent it? There is a lesion in the distal, just before the crux. There is a lesion distal to the crux in the PLB, and there is a lesion in the mid up which appears to be not significant. Can I predict the result prior to PCI? Pullback showed the instantaneous wave in this case. It was positive here. A point value less than 0.89 is positive. So this is 0.56 is clearly positive in the distal most lesion. And as we pull back, we know agar jahan pe normal ho jaye, that place, only that lesion has to be done. So here it is 0.98. That means this lesion is the distal most is the significant lesion. Just stent that, and we had a very good result, the FFR. So that's all. So that's basically my take on it, that one has to use clinical history judiciously, and one has to try to integrate more and more physiology. So that makes us wiser clinicians. Thank you.
Thank you, Dr. Rohit, for excellent talk. You know, as Dr. Rohit have already elaborated how to use revascularization in our day-to-day practice. And the most important thing is clinical history and clinical setting. And then comes the echocardiographic parameters, then angiographic parameters. And the most important thing, whether you are dealing with the acute coronary syndrome or chronic stable angina, that is the most important thing. Suppose you are dealing with the ST elevation MI and patient is within 12 hours of the window period, and if you can afford, then the primary angioplasty is the gold standard. But if you are dealing with the chronic stable angina, then all ifs and buts arises. And the important to understand is that in chronic stable angina, your plaque is stabilized, and once you do an intervention, you simply make stable plaque unstable. So some sort of controlled acute coronary syndrome like condition you create. So your indication of doing angioplasty must be certain. And a lot of things depends. Suppose you are having a 99% blockage at the end of left LAD artery or RC artery, where you are hardly any 5% area is left to be supplied. So in that case, intervention is not required. And suppose you are having looking 50% stenosis in proximal LAD, FFR may come, will come positive in most of the cases because larger myocardium area is at the risk. So it depends where the blockage it is. So in case of left main, even 50% stenosis is important. And in the case of very distal, even 99% you don't need to intervene. And as far as event is concerned, if you are giving full optimal medical therapy, in terms of true mortality and myocardial infarction result, hardly there is a difference. You might have seen a lot of practice in your clinical practice. They are chewing sorbitrate for last 10, 20 years and MI have not happened. And you will see 50% of patient, they will not have any angina, but they will suddenly present with the acute myocardial infarction. In 50% of the cases, you don't have any preceding hypertension, diabetes, ACS or any pre-infarct angina. So now the FFR and latest is IFR. The advantage of IFR is you don't have to give adenosine and single wire is there and it is a more patient friendly. And when it should be utilized, I have some reservation in my mind. If you are critically looking lesion, then I am always scared to put wire across it because your IFR may become normal. Your IFR become normal, but I think intermediate cases, all intermediate cases, certainly it should be done. Critically looking lesion, if you are in proximal area, I think you should go. If patient is having a history of angina, then you should, I think, go straight. In 90% lesion, classical angina is there, then I think this sort of patient don't require physiological assessment.
Absolutely. If your lesion is looking absolutely critical, you actually don't need to do FFR. If it is,
Because
even if your patient has stable angina, unstable angina, so at all not needed. Even if your patient is stable and you find a lesion, as he's saying, it appears critical, it is stupidity to put a wire across just to find out if it is वो जो सामने दिख रहा है clearly.
The patient is having the history of angina.
Patient is having history of angina. So you have given optimal medical therapy. Then you should intervene.
70% borderline lesion, history is doubtful. In some sets, that subset of patients.
Yes, really ultimately it is those set of patients.
The last one.
The last one where I'm sure the RCA you're talking of. We just put the stent in the RCA distal in the PLB. And before the crux, after the crux, everything, we did a pullback. You can do pullback or FFRs of all these. The instantaneous wave also can be done in a pullback. The FFR also you can do in a pullback. The only thing is the difference between an instantaneous wave and a FFR is that in instantaneous wave, that element of antigrade and retrograde, you're basically measuring pressure. So when you're looking at FFR, usme the pulsatility is also included. Forward pulse, jo distal circulation में जा रही है, जो LED में, for example, that and the retrograde pulse that is also coming, that is also factored in an FFR study. Where in instantaneous wave, what is happening is it is measuring only for a fraction of the time. So you are getting a wave free form. So instantaneous wave. In that patient or in such patients, that's the idea of using physiology. They don't put 4 stents, put one which is important, and tell your patient that this is the one which is culprit. You don't have to revascularize the whole. Atherosclerosis is a progressive disease. He will at any cost need re-interventions in future. It is not a insurance against कि हाँ आज हमने कर दिया तो कल जरूरत नहीं पड़ेगी. That's not going to be.
I would like to end this session, and for session 2, we are having the chairperson, Dr. P.R. Sinha sir, Dr. Vikas Agrawal sir, Dr. Ashish Jaiswal, and Dr. Sanjay Kumar. I think none is here, so I will request Dr. A.K. Singh sir to continue, and I will request Dr. Monica ma'am to come on the dais. And first speaker is Professor Dr. Akshay Pradhan. He is from Department of Cardiology, King George Medical University. and he did MD and DM from King George Medical University. He has more than 50 publication to his credit. So the topic is of Dr. Akshay Pradhan is management of atrial fibrillation in acute coronary syndrome or post PCI patient, dual versus triple therapy. Over to Dr. Akshay Pradhan. Dr. Akshay, can you hear me?
Yes, I can hear you, Dr. Alok. Thank you so much for this wonderful opportunity. I'll try to share the slides. Okay, I think the slides are visible by now.
Yes, it is visible.
Okay, thank you, Dr. Alok, for organizing this meet amidst the waning of, I think, COVID wave, and it's a interesting lectures in the scenario. So again, I have a very difficult topic at my disposal because nobody knows what is the optimal antithrombotic regimen in patients who are having atrial fibrillation and who are also undergoing a PCI or they're having an ACS. Two options we have, dual versus triple therapy, which way to go? Nobody has the answer, but yes, recent research has given us some guidelines. So before we proceed, I think you all are aware that acute coronary syndrome has multifactorial pathophysiology, including plaque erosion, platelet activation, thrombin production, and we all are doing it, and PCI is now the standard of care. Now, use of PCI warrants a dual antiplatelet therapy to prevent atherothrombotic recurrences. However, if your patient has ACS or is having undergone PCI, and if he has AF, then his ischemic risk remains high. On the other hand, atrial fibrillation is a common arrhythmia. Its incidence is increasing, and so is the incidence of CAD because the risk factors are common, like age, hypertension, diabetes, smoking. So both AF and CAD are increasing. And if you look at acute MI, then the incidence of AF is somewhere around 10 to 15%, which has decreased from the pre-thrombolytic era, but mortality remains high. So the crossroad of AF and ACS is a troublesome one. And again, this is the Western data showing that almost 20 to 30% patients who with CAD might need a PCI. But here we are restricting ourselves to primarily ACS and primarily PCI. As our population is becoming elderly, the CADs of incidence is growing and also the AF. Now, what is the treatment? The treatment needs a combination of oral anticoagulation for AF and antithrombotic antiplatelet therapy for PCI. So you need to combine AF therapy, that is the anticoagulation, and ACS or PCI therapy, that is antiplatelet therapy. Why not individually either of them? Because we know from the ActiveW trial that DAPT is not the standard of care for AF. Similarly, we know from the STAR study that warfarin or oral anticoagulation is not the standard of care of coronary stents. So if you need to have both the ends, then probably you need a combination of antiplatelet and antithrombotic therapy. But then as you go on increasing the combination, the risk of bleeding increases. So if you are looking at warfarin as a standard, then triple therapy increases the risk of bleeding by almost 3 times. And post-PCI bleeding is not benign, and we know that the mortality can rise somewhere between 3 times to 4 times, as seen in various studies. So we have a difficult problem at hand. We need to combine antiplatelet therapy with antithrombotic therapy. We get benefits, but we also know that this combination leads to increase in bleeding. So we are, you can say, in a devil's dilemma. What should we do? And why post-PCI bleeding is harmful? Because bleeding ultimately leads to shock, leading to transfusion, DAPT discontinuation, ultimately all this pathophysiology leading to increased mortality. So just a reminder of what are the current antiplatelet and antithrombotic therapies we have in mind or in practice. And antiplatelet therapy, we all are aware there are 3 different agents available for us. And again, this is the old guideline of ESC. Over the past 5 years, multiple new studies have emerged of combination therapy of antiplatelet and antithrombotic therapies. We'll discuss one by one. We'll see what are the pitfalls of these studies and we'll try to find a common ground. So let us look at the clinical evidence of combining antiplatelet therapy with warfarin. The first big trial was the WOS trial, published 6-7 years ago, where almost 573 patients undergoing PCI were randomized to a combination of vitamin K antagonist and clopidogrel called as a dual therapy versus the standard of care, that is vitamin K antagonist plus dual antiplatelet therapy called the triple therapy. You can see at the end of 1 year, the primary endpoint of bleeding was significantly decreased almost 44% decrease in bleeding. And comparing the blue bars, there was no difference in white bars, that is the death by stroke or TBR. Another trial was the ISA triple trial, again somewhat smaller study, but here it compared two different regimens of triple therapy. A short triple therapy of clopidogrel with 6 weeks and a longer triple therapy of clopidogrel with 6 months. So again, however, the trial failed to show any difference between the two arms with respect to TB major bleeding and cardiac death. And if you look at the number needed to treat in worst, it was also worst. On the surface, looks a very impressive trial showing that dual therapy is far better than triple therapy. But both primary endpoint and secondary endpoints were decreased. However, there was somewhat an increase in all-cause mortality, which was driven by non-cardiac mortality. So the trial had an open-label design where the physician knew that which drug he was giving to which drug. The sample size was small. Importantly, the trial was underpowered for ischemic events. So even if you didn't find any difference, but it was underpowered to ischemic events. Major bleeding, which was decreased, was only TB major and minor bleeding, minor and minimal bleeding. There was no effect on major bleeding. The bleeding rates in the triple therapy arm was significantly higher, probably because proton pump inhibitors were not used. And we could not explain why non-cardiac mortality was decreased, although most of the therapies were looking at cardiac therapy. And 30% of patients were on atrial fibrillation, were on oral anticoagulation or other indications like LV aneurysm or venous thromboembolism, etc. So worst, they did produce results, but it was a trial with multiple challenges. But it at least said that there is no need for going for the 1-year triple therapy as was standard of care in 2011 and 12. After that, till that time, I think warfarin was or acetron was the only anticoagulation available for us. But post 2010, we have the era of NOACs, these novel oral anticoagulants which act either on the thrombin or at factor 10A. They have multiple advantages. They don't need regular PTNR monitoring. They have lesser food and drug interaction. They have rapid onset and offset. They have predictable anticoagulation and they produce less bleeding. And in the 4 big trials, we all are aware, there is the scales are tilted in favor of NOACs with respect to systemic embolism or stroke. And with respect to bleeding also, if you're looking at intracranial hemorrhage, then there is almost 50% reduction in bleeding, although there is a small rise in gastrointestinal bleeding. So now the stage was set that we tried a combination of antiplatelet agents with NOACs. So the first trial in this series was the Pioneer AF PCI. It was the, you can say, a pilot test trial, and it randomized almost 2,000 patients to receive either a low-dose rivaroxaban with a single antiplatelet agent, or very low-dose rivaroxaban with dual antiplatelet agent, or standard triple therapy. And the primary safety outcome was bleeding. Remember, all the trials which we will discuss, the primary endpoint is always the bleeding, because most of the studies are underpowered for ischemic events. And as we discussed in previously, bleeding was a concern. We knew that the triple therapy or an addition of anticoagulation is going to work, but the bleeding is a challenge. So bleeding was the primary endpoint in majority of the studies. And if you look at the baseline characteristics, majority of them were taking clopidogrel as the P2 vital inhibitor. Prasugrel anticoagulant ratio was definitely less. And as expected, the rates of significant bleeding were lower in the groups receiving rivaroxaban compared to the triple therapy. However, there was no difference in rate of death from cardiovascular causes. So, from the primary aspect of safety, both groups of rivaroxaban, whether it was low dose or standard dose, were doing less bleeding. But with respect to safety, there was no difference in majority of groups. So the study concluded that if your patient of AF is undergoing PCI with placement of stent, then you can administer a low dose rivaroxaban plus a single P2 vital inhibitor, or you can have a very low dose rivaroxaban plus dual antiplatelet therapy if you are looking at bleeding. Building upon the Pioneer AF trial, the next trial was the Redual PCI, where dabigatran was used instead of rivaroxaban. Again, there were 3 different arms. The standard triple therapy arm comprising of warfarin and dual antiplatelet therapy. Then there was 2 dual therapy arms where different dose of dabigatran were combined with a single P2Y12 inhibitor. Again, the trial was almost for a year, and it tried to test the safety and efficacy of two different regimens of dual therapy. Again, bleeding was the primary endpoint, as I previously explained. And baseline therapy was again, they were relatively high-risk patients with a CHAD score more than 3. And again, with respect to bleeding, dabigatran therapy always had a decrease, almost 50% reduction in bleeding. With the 110 milligram was more beneficial with respect to bleeding, but both the doses were beneficial with respect to bleeding. 48 and 28% reduction in bleeding with 110 and 150 milligram doses. So the trial tried to show that the drug reduces bleeding. It did reduce. Secondary outcomes, rate of ICH, rate of ISTs bleeding again were lower, and there was no difference in ischemic events. So similar to Pioneer AF, this trial also concluded that patients of AF who had undergone PCI, again, if you give a dual therapy with dabigatran, the risk of bleeding is going to be higher. There was no difference with respect to thromboembolic events. So two successful trials in 2013 and 15 led to actually a surge towards the use of NOAC-based therapy in patients undergoing PCI. Then there was this Augustus trial. It was a third in series. It used apixaban to 5 milligram BD in patients again undergoing PCI. But the trial had an additional aspirin randomization arm also, where in each arm there was a comparison between aspirin and placebo. And again, the bleeding was the major endpoint, and ischemic events were secondary endpoint. And if you look at the major primary endpoint, again, bleeding was reduced by almost 30% in the apixaban arm, whether it was major, whether it was minor. In secondary events, there was not a significant difference between both arms. Surprisingly, the bleeding with apixaban arms were even lower than aspirin. That was very surprising, and probably this trial nailed the last coffin in aspirin therapy after the ARRIVE and ASCEND trials. So even in secondary prevention now, people are looking towards aspirin-free strategy after the Augustus trial. The last in the series was the ENTER-SAFE PCI with edoxaban. Though small, again, the trial was, it was a Danish trial and Spanish, European trial, and it was a 1-year trial. Again, primary endpoint was bleeding at 12 months. And you can see that edoxaban-based therapy, dual therapy with clopidogrel, was non-inferior to vitamin K, clopidogrel, and aspirin, or triple therapy, as we see. However, you will see that in the first 14 days, the hazard ratio with edoxaban therapy was very, very high. This is because during that period, actually, warfarin patients did not achieve their INR. So bleeding with warfarin was low, and comparatively, edoxaban bleeding was higher. Despite this disadvantage with warfarin, edoxaban could not prove superiority to the drugs. So if you look at these 5 to 6 trials and you summarize them, and you will see that these are fairly big trials, and many patients had ACS patients enrolled them. So these were a fairly good number of trials encompassing almost 10,000 patients. And what is the uniform signal? Bleeding is uniformly reduced if you are using a dual therapy with respect to whether NOAC or whether you are using a VK. Now we previously know that NOACs decrease bleeding with respect to VK. So probably dual therapy is the standard of care based on these 5 to 6 trials. And if you look at meta-analysis, again, based on these 6 trials, again, you will see that bleedings was significantly reduced across the board, whichever trial you took it. And ischemic events were almost similar, or as I said, they were underpowered. But does that mean that there is no role for a vitamin K antagonist in PCI with AF? Let's hear a few arguments. The first thing is that, as I said, most of the trials are underpowered for ischemic events. And this is not my thinking. This is the acknowledged in the trial list by each of the 4 studies. In fact, if you look at the redual PCI, in 110 milligram dose of dabigatran, there was significantly increased thromboembolic event. But this was counterbalanced by a higher decrease in bleeding events. In clinical practice, bleeding events are higher than ischemic events. So if your trial is not powered properly, then you will miss those ischemic events. And 3 separate meta-analyses have shown that if you are using a NOAC-based dual therapy, then you have 50 to 60% risk of stent thrombosis. There is almost concomitant 10 to 20% increase of myocardial infarction, but that did not reach statistical significance. And most of these stent thrombosis was with a lower dose of dabigatran. And the meta-analysis say that if you give a short course of triple therapy for 1 month, probably you can circumvent that. Secondly, the duration of a triple therapy was not uniform across various studies. Worst used a 12-month dual therapy, so bleeding was higher, whereas NOAC-based studies had, some studies had 1 month, some study had 3 months, some study had 6 months. So as practice changed from 2010 to 2016, the triple therapy duration varied, but the comparator arm was always triple therapy. So it is very difficult to compare one trial with another where the triple therapy duration is varying. Thirdly, most of the studies compared triple therapy with dual therapy. This is just similar to comparing apples and oranges, because we know that dual therapy, as seen in the previous first or second slide, that if you hierarchically increase the your bleeding risk increases. And direct comparison of VK based triple therapy and NOAC based triple therapy was not done in 2 of these studies. So probably we need a trial which is comparing both the triple therapies head to head, which is not seen. And lastly, if you are looking at mechanical heart valve, pregnancy and severe MS, you have to look at vitamin K antagonists. Of course, I think the Invictus trial is soon going to publish its results and probably will throw some light on use of rivaroxaban in severe MS. So despite these impressive results, there are some reservations with respect to these NOAC agents. However, if you're looking at bleeding, then definitely the dual therapy or a NOAC-based triple therapy is the way to go. And as we know that when we combine these 2 therapies, there is a risk of bleeding. So there are multiple methods which we can use to mitigate bleeding. That is, you can use radial access. The aspirin dose, whenever used in triple therapy, should be less than 150 or preferably 75. Use a PPI, because that can increase the risk of GI bleeding both with NOAC, dual and triple therapy or warfarin. Then you can de-escalate the therapy. That means after 1 month of therapy with dabigatran, P2 vital inhibitor, that means if you are using prasugrel and ticagrelor following PCI, then you can de-escalate to clopidogrel after 1 month. You can shorten the duration of DAPT, as shown in Twilight and TICO studies, and you can use Has-Bled score to justify, to see patients who are at high risk of bleeding. Then you can give a NOAC with them, or and even if you are using a warfarin, then you should carefully look at the patient is in TTR. With respect to clopidogrel, a recent meta-analysis compared in the 4 trials what is the benefit of using clopidogrel in comparison to ticagrelor or prasugrel. And you will see that if you use ticagrelor or prasugrel, then your bleeding rates are higher without any benefits in MACE. So currently, I think that it's wise to use only clopidogrel if you're using in combination with oral anticoagulation therapy, whether it is VK, whether it is NOAC. Although there are multiple studies going on ticagrelor and prasugrel in combination with NOACs, but currently those results are pending. And here you can see in this meta-analysis that your bleeding risk is low with clopidogrel. There is no difference in ischemic events. So based on these therapies, the guidelines have now shifted towards a shorter triple therapy. The European consensus is that you should give triple therapy for 1 week and maximum 1 month. If your patient is a very high risk, you can keep your triple therapy to less than 1 week. If your patient's ischemic risk is high, you can go up to 1 month. The American guidelines say that you don't need to give an aspirin at discharge at all, unless your patient is very, very high risk. But both the guidelines say that it's time to move towards a dual therapy, and that to a NOAC-based dual therapy. So the crossroad between coronary artery disease requiring PCI and AF requiring anticoagulation is not infrequent. As I said, this number can be somewhere between 10 to 30%. In such a situation, you need triple therapy. That is a combination of dual antiplatelet therapy plus oral anticoagulation, which can increase your bleeding by 3 to 5 times, roughly 4 times. And bleeding increases mortality by 3 times in post-PCI patients. And hence, because NOACs have emerged as an alternative to VK, so dual therapy with NOAC has now emerged as a viable alternative. There are 4 individual RCTs with NOACs and 2 RCTs with VK, and multiple meta-analysis have shown that a dual therapy based on NOAC is significantly effective in reducing bleeding. There is a small increase in risk of stent thrombosis, especially when your suboptimal doses of NOAC are used. Hence, if you apply careful attention to your access site, aspirin dose, concomitant DAPT duration, Has-Bled score, and other, if you take all those precautions, probably you can navigate the pathway of combining antiplatelet and antithrombotic therapy with success. Thank you.
For your lucid talk. I think no questions are there in chat box. So thank you again.
Thank you, sir.
I welcome all of you to the Hard India Conclave. The speaker for the session 2, CABG in LV systolic dysfunction, is Dr. Sanjay Gupta. He is Director, Department of Cardiothoracic and Vascular Surgeon at Fortis Hospital, Vasant Kunj, New Delhi. He has performed over 5,000 cardiothoracic and vascular surgeries till date. He's doing all kinds of cardiac surgeries, congenital CABGs, valve surgeries. And in addition to this, he's also doing vascular as well as thoracic surgeries. His surgical quality achievements are numerous. They are as follows. The surgical quality can be ascertained by the fact that more than 70% surgeries are being done without any blood transfusion. He has achieved his mean blood transfusion rate during a whole hospital stay in rate 1 in cardiac surgery of less than half unit. His USP lies in producing very good surgical results in very sick emergency patients, such as during cardiogenic shock and patients with acute MI. He has gained reputation in doing cardiac surgeries in chronic kidney disease patients. I welcome you, sir, to this session. I hand over the mic to you. Welcome, sir. Welcome, Dr. Sanjay Gupta.
Thank you. Are you listening me?
Yes, sir. We can
Yes,
hear.
Thanks for the nice introduction. I am sharing my slide. Firstly, I wish to thank Dr. Alok Singh for organizing again after a gap of 1 year due to the COVID pandemic, this Heart India Conclave. I also congratulate him to organize this hybrid meeting after such a devastating period for last 1.5 years. My topic is CABG in LV dysfunction. So different societies and guidelines defined the LV dysfunction in different ways. Heart failure guidelines, they divided the ejection fraction, HF preserved ejection fraction when LVEF is more than 50%, mildly reduced ejection fraction, LVEF is 41 to 49%, and heart failure with reduced ejection fraction, LVEF is less than 40%.
Slides are not visible.
Yeah, slides are visible.
Not. Open करिए slide open करिए sir.
In my screen, slides are there.
Share the
I think you have to the slide and share this.
first open the slide and then
Yeah. Slide are not open. Just wait. Is it visible now?
now it is visible.
Oh, thank you. Thanks a lot. So different guidelines has classified the LV ejection fraction in different ways. Heart failure guidelines, this is the preserved ejection fraction when it is more than 50%, mildly reduced ejection fraction 41 to 49%, and reduced ejection fraction less than 40%. So in this present topic, we are discussing this particular group of the patients. Whereas coronary revascular guidelines, LV dysfunction is when it is less than 35%. So whenever we discuss these guidelines, then ejection fraction will be 35%. Whereas when we produce our results according to the Euro score system or STS score, severe LV dysfunction is less than 30%. So CABG in LV dysfunction, it required in two situations: chronic coronary syndrome and acute coronary syndrome. In chronic coronary disease, or which is equivalent to chronic stable angina, CABG in this situation will be discussed in with the available evidences in this particular presentation. There are last 2-3 slides with acute coronary syndrome or ACS, where the LVEF is less than 30%, and majority of these present with the cardiogenic shock if they are having a STEMI, and they needed urgent revascularization by PCI or CABG as per guidelines. So this is the guide. This is the 2018 European Society of Cardiology guidelines for the all patient according to the symptoms. So here this is class 1A indications, 2 or 3 vessel or multi-vessel disease with stenosis more than 50% with impaired LV function. So my talk is basically on these patients with special reference to the hemodynamically significant coronary stenosis in the presence of limiting angina or angina equivalent with insufficient response to optimized medical therapy. Means we are giving anti-anginal therapy and symptoms persisted. This is also class 1 indication. In this presentation, special emphasis is also be given to a large area of ischemia detected by functional testing, more than 10% of left ventricular volume or abnormal invasive FFR, as discussed by one of the previous speaker. These all class 1 indication, but we will see what its effect on LV dysfunction patients. Directly coming on to the guidelines for heart failure. In the same year, 2021, they have recommended the intervention treatment for this particular group of the patient. So they say that CABG should be considered as first choice revascularization strategy in patients suitable for surgery, especially if they have diabetes, and for those with multi-vessel disease, it is class 2A indication. Whereas coronary revascularization should be considered to relieve persistent symptoms of angina or an angina equivalent in patients with reduced ejection fraction heart failure, chronic coronary syndrome, and coronary anatomy suitable for revascularization despite optimized medical treatment, including anti-anginal treatment. Minded that it is for the reduced class 2A indication, but for the preserved and mildly reduced, this indication is class 1 indication in same guideline. They say that in LVAD candidates needing coronary revascularization CABG should be avoided. Further, class 2B or class 2BC indications means you can avoid these. You can also avoid these particular surgeries. Coronary revascularization may be considered to improve outcomes in patients with reduced ejection fraction, chronic coronary syndrome, coronary anatomy suitable for revascularization after careful evaluation of the individual risk to benefit ratio, including coronary anatomy, that is proximal stenosis more than 90% of large vessel disease, stenosis of left main or proximal LAD, comorbidities, life expectancy, and patient's perspective. Matlab, you should discuss all these things among the cardiologists with the patient and then decide for the surgery. PCI may be considered as alternative to CABG based on heart team evaluation considering coronary anatomy, comorbidity, and surgical risk. Something about the ischemic heart failure. Actually, its incidence is very high. It is 40% in International Congestive Heart Failure Registry and 70% in Trivandrum Heart Failure Registry. What does it mean? If you have 100 patients of heart failure, 48% here because of ischemia and 70% here because of the also ischemia. That's why it is very important to treat or give some treatment to them. Thus, heart failure is not only due to the chronic LV dysfunction, but also due to structural disorder such as MR, LV aneurysm, and acquired VSD, and they require surgery, no doubt about it. So, we are not discussing these patients here. It can also be due to the reversible LV dysfunction due to significant obstructed CAD resulting in reversible ischemic myocardium or hibernating myocardium. We will discuss it because it is very important part in these patients. Why this heart failure is so much important? Actually, there is a heart failure summit in 2015 in Barcelona, Spain, and they found that in any type of heart failure, 5-year mortality is 65% to 68%. It is too much. That's why it is important to give some treatment to improve the life of these patients. What is the reversible ischemic myocardium? This concept of it emerges from the coronary artery surgery study which were done in 1970s. As there in some cases of CABG, LV function get improved, and it resulted in improved survival and decreased major adverse cardiac and cerebral events. Conversely, revascularization in patients not having viable myocardium have not shown any structural alteration and clinical benefits. Some studies suggest that surgical revascularization is more beneficial in patients with angina rather than dyspnea, according to guideline heart failure in 2008. So, how can we identify the hibernating myocardium? The very crude method is ECG, shows R-wave progression. In echo, we can see the LV wall thickness in area of dysfunction. Or low dose dobutamine echo, single photon emission tomography, PET scan, cardiac magnetic resonance CMR, and thallium, resting, and stress. This is an algorithm when we should operate in these patients. Actually, this is a review article from where I have taken it. So, in the area of LV dysfunction or where the RW is present, we see the LV wall thickness in the area of the dysfunction by echo or by CMR. If echo is not satisfactory, is wall thickness is less than 5 to 6 millimeter, probability of the improvement of LV function is less than 5%. If wall thickness is more than 5 to 6 millimeter, probability of improvement of LV function is more than 50%. So here we do the low dose dobutamine stress or SPECT. If viability is there, revascularization. Or if viability is not there, we do some testing by CMR, PET, or thallium, or there is a mismatch, which after given stress, if mismatch is less than 50% revascularization and mismatch is more than 50%, no revascularization. In that method, they have given this algorithm. They have made some criteria also. There are some major criteria or minor criteria. There should be more than 4 or 4, either 4 major criteria, 3 major plus minus, 2 major plus minus. LV wall thickness less than 5 to 6 millimeters. No response to LDDE, negative for viability by SPECT or thallium, PET negative for hibernating myocardium, and this is LVEF less than 20%, and by echo, if heart is very large and diastolic volume is more than 5.5 centimeter per meter square, or this is the diameter and this is the volume, and this is the systolic volume, which is more than 90 ml per meter square. By angio, this is the criteria. If it fits into the criteria, then probably we should avoid surgical intervention. Actually, this study showed, this is the coronary artery surgery study 1970, showed that a subgroup of patients with coronary artery disease, angina with reduced LV function had a significant survival benefit after CABG as compared to those treated medically. And here they found that the LV function get improved. That's why the concept come of hibernating myocardium. But now, since then, newer drugs have come up and we have more guideline directed medical therapy with newer drugs. So there is a need of a new trial. For the same, STIS trial was being done, and it showed that a median follow-up at 56 months failed to show significant difference between CABG and optimized medical treatment group for all-cause mortality, though cardiovascular death were lower in CABG group, which is statistically significant. Now we are coming to the STIS trial. The results were published in 2011. They enrolled the patient from 2002 to 2007 and published their result in 2011. The background was the coronary artery disease is a major substrate for heart failure and LV dysfunction, which we have already seen. The role of CABG in patients with CAD and heart failure has not very well clearly established. Again, the same in 1970s, RCTs of CABG versus medical therapy for chronic stable angina excluded patients with severe LV dysfunction. Actually, only there were 4% symptomatic patients with heart failure, and in that particular group of the patients, the mean LVEF was 42%. After that, there are major advances in surgical care and medical therapy, both which rendered the previous data obsolete for clinical decision making. The observational analysis suggests the role of CABG for heart failure and LV dysfunction, as CABG is increasingly utilized for these patients, yet substantial clinical uncertainty remains. So they started this surgical treatment for ischemic heart failure trial. It was done in patients with heart failure, LV dysfunction, and CABG amenable to surgical revascularization. CABG added to intensive medical therapy with decrease, and it will decrease all-cause mortality compared with medicine alone. These were the primary and secondary endpoints. The inclusion criteria: left ventricular ejection fraction less than 35% within 3 months of trial entry. The coronary artery disease should be suitable for CABG. Medically eligible patients, the criteria was absence of left main coronary artery disease as defined by an intraluminal stenosis of more than or equal to 50% patients, and absence of CCS class 3 angina or greater, angina markedly limiting ordinary activity. Actually, these two group of the patients went into the surgical group. So exclusion criteria: recent acute MI, cardiogenic shock. So they have not included the patient of ACS, or there is a plan for PCI. Aortic valve disease requiring valve repair or replacement, non-cardiac illness with a life expectancy of less than 3 years or imposing substantial operative mortality, they were also excluded. There were 1212 patients, 602 randomized for medical therapy and 610 randomized for CABG. It is a multicentric trial. These were the propensity match analysis, almost matched. This is the medications, where it is almost matched. In CABG group, out of 610, 555 underwent CABG surgery, and median time was 10 days from enrollment to surgery. 95% performed electively. Arterial conduit more than 1 were 91% of the patient. Venous conduit more than 1, 86% of patients. Total graft more than 2% were in 88% patients. The average length of stay was 9. The median is 9, with the interquartile ratio was 7:13. They were followed up, and follow-up was 99.6%. Only 5 patients were not evaluable with median follow-up of 40 months. Overall duration of the follow-up, mean was 56 months. This is the result. For all-cause mortality, the p-value is insignificant. So all-cause mortality was same for both the group. But if we see the death for cardiovascular hospitalization, death or cardiovascular hospitalization, CABG is far better with p-value of less than 0.001% patients. Actually, among 602 randomized to the medical treatment, 65 went into the surgical group. It is a open-ended trial. It was not a blind trial, and both the group prefer which patient should go on which side. So that was the limitation of this trial. This was the adjusted as treated and per protocol analysis of the primary endpoint, although informative, but should be considered provisional. The STIS trial was not blinded, and non-fatal outcomes could have been influenced by the knowledge of the treatment provided. They have summarized its trial in that in patients randomized to the stitch, there was no statistically significant difference in all-cause mortality between medically treated patients and medical plus CAVG treated patients. Medical therapy with CAVG reduces cardiovascular mortality and morbidity compared to the medical therapy alone. When randomized to CAVG patients are exposed to an early risk, because early mortality is much more with CAVG patient than medical therapy alone. We compared CAVG with contemporary evidence-based medicine alone among high-risk patients with CAD, heart failure, and left ventricular dysfunction. Despite the medical adherence with operative results achieved, stitch-like patients remain at substantial risk otherwise also. They say that 5-year mortality risk with medicine only is nearly 40%. So they need that there should be some extension study which will test the durability of these results at 10 years. So recently stitch extension study is published with the result of 10 years, and these were the results. All cause mortality for CABG and medical therapy, there was difference but not much difference. P-value is 0.02, 58.9% versus 66.1% in favor of CABG. Whereas there is significant improvement in CV mortality, cardiovascular mortality, 40.5% versus 49.3%. All cause mortality or MI, P-value is just 0.3, 61.6% versus 7.9%. They particularly found that older patients had more comorbidities such as type 2 diabetes, chronic kidney disease. That's why all-cause mortality tended to be higher in older compared with younger generation in both the arms. This is the age. You see, this is the all-cause mortality and this is the CV mortality. The difference is much more when the patients are older, and difference minimum in the patient 60 to 67 age group. So in stitch extended study, they give more emphasis on the rehospitalization. So we are coming to the rehospitalization. Number of all-cause rehospitalization was much more with the medical treatment only. Similarly, number of CV rehospitalization, they are much more in the medical treatment only. Number of heart failure hospitalization, they are also much more in the medical treatment only group. Further, in stitch extension study, you see here only the all-cause hospitalizations, medicine 1350, CFG 1199, p-value is less than 0.001. CV hospitalization, p-value in favor of CABG less than 0.001. Heart failure hospitalization, CABG is better, p-value 0.005. Non-cardiovascular hospitalization. Here, non-cardiovascular hospitalization, more number of patients of CABG group get admitted. This is the mean cumulative incidence of all-cause hospitalization during the entire 9.8-year follow-up period. This is the CABG group. Hospital hospitalization number of times are 3.5%, 3.5 times and 4.5 times. Now, we compare the PCI versus CABG in these type of patients with diabetes mellitus. Actually, there is not much literature. We have found out only this particular series, which was recently published in 2018. In this propensity match study, outcomes were compared for patients with coronary artery disease, diabetes, and LV dysfunction, which treated with PCI or CABG between 2004 to 2016. PCI compared with CVG associated with a higher risk for major adverse cardiac MACE in cohorts with ejection fraction 35 to 49%. P-value is 0.001%. Whenever PCI compared with CVG associated with a higher risk for major adverse cardiac and cerebrovascular events in cohorts with ejection fraction 35 to 49%, CVG was better. Treatment with PCI was associated with an increased risk for death in both 35 to 49% patient and EF less than 35% patient. Stroke rate did not differ between PCI and CABG in either ejection fraction cohort. PCI was associated with increased risk of MI in the EF less than 35% cohort, and repeat revascularization occurred more frequently in patient in treatment in PCI in both cohort of ejection fraction. They concluded that actually presently available large randomized controlled trials have not enrolled these patients with near normal EF. Thus, this study provides the first data to suggest that patients who have CAD, diabetes, LV dysfunction, they benefit from CABG as it offers a long-term overall survival benefit, reduced risk for MI and repeat revascularization, and no increased rate of stroke compared with PCI for this subgroup of patients. Apart from those patients who have prohibitive surgical risk or technical factors limiting surgical revascularization, CABG should be considered first-line therapy for the treatment of multivessel CAD patients with diabetes and LV dysfunction. That's why CABG is better in this subset of patients. Now, acute coronary disease or acute coronary syndrome with LV dysfunction. So, this particular group of the patients, they are discussed many times at every conference, and the early intervention of PCI is always preferred. But whenever there comes the LV dysfunction, where ejection fraction is less than 35%, there is some role of CABG also. So I have not taken in discussion ACS and STEMI patients. I am taking only STEMI patients with ACS, where the CABG is very limited indications. PCI is always preferred. CABG should be considered in patients with ongoing ischemia and large areas of jeopardized myocardium if PCI of the IRA cannot be, infarct related artery cannot be performed. Or emergency CABG is recommended for patients with cardiogenic shock if the coronary anatomy is not amenable to PCI. Another indication is for the mechanical complication of acute coronary syndrome or MI. So here I have my own data. So I am presenting this own data since August 2009. The CABG, the CAD STEMI with cardiogenic shock, 64 patients were operated, and results were like that. In 64 patients in hospital, 30 days mortality was 14, loss to follow-up was 5. So if we subtract these patients and exclude loss to follow-up also, among 50 patients, 14, 50, 45 patients, only late death was 9 with a median follow-up of 68 months, more than 5 years. So there is mortality of nearly 20%, and 80% is still survive after mean follow-up of so much months. This is the how these 9 patients were expired. Cardiac were 4, cancer were 2, infections were 1, intracranial hemorrhage 1, and 1 unknown. So for this particular talk, we can conclude that CAD, coronary artery disease, should be assessed and medical therapy optimized for all patients presenting with heart failure. And this particular therapy should be continued to postoperative period also. Decision making for CABG is very complex, should be individualized and take into account the short-term risk for long-term benefit. What does it mean? That surgery have some mortality risk also in these patients. Before surgery, patient should be investigated for some strong evidence for reversible ischemia, whatever the methods are available at that particular city or town. CABG should be considered to relieve persistent symptoms of angina or an angina equivalent in patients with reduced heart failure ejection fraction, chronic coronary syndrome, and coronary anatomy suitable for revascularization despite OMT, including anti-anginal drugs. Thank you very much.
So thank you, Dr. Sanjay Gupta, for your very lucid presentation. Anybody, any questions? Anybody wants to ask any question? Yes, sir. Can you give him the mic?
Thank you, madam.
Thank you, Dr. Sanjay. This is a very lucid and brilliant presentation. I have a couple of questions for you. This one question is about assessment of this patient for reversible ischemia, to know about this hibernating myocardium. So, in your experience, which is the preferred modality of diagnostic modality you use to assess this kind of patients?
Actually, in our hospital, PET is not available. We have the thallium. So we usually use thallium. But the problem of thallium is that whenever the patient of less than 35% ejection fraction, when we give the patient stress, some of the patients go into left ventricular failure, specifically in those category of the patient where the ischemia is much more. So ideal is the PET scan. PET scan is give more information.
You also mentioned one of the in your list, low dose dobutamine.
Dobutamine. Actually, similarly in thallium also we give the dobutamine to give stress if patient is not able to take stress walk with the treadmill. So same thing happen in dobutamine stress echo also. That's why I mentioned that in this subset of the patient with less than 35% ejection fraction, low dose dobutamine therapy is better than the full dose dobutamine.
Yeah, you're right, because we don't have PET as well. But whenever we wanted to assess this hibernating
This is a very good, very good. But
the problem is that our cardiologists turn them down, saying that there's a fear of
failure. Yeah. And further, low dose dobutamine therapy, we cannot quantify the hibernating myocardium, whether it is 10% of the LV volume or not, which is an indication. With the thallium and PET, we can quantify.
Thank you.
Thank you, sir.
MRI, I think, having the emerging role in deciding.
Yes. They have emphasized that CMR is a good role, but how they achieve it, unfortunately, such a good radiologist we don't have. That's why we are not using it. But as per literature suggests, CMR has a good role. And yes,
CMR is very underutilized, and it is a very objective test.
Yes.
And if you see the thickness of myocardium,
yes,
is 7 mm or more in the presence of coronary artery disease. I think thickness can be very accurately measured on the CMR, and even the ejection fraction and volumes are very well visualized on the CMR.
CMR.
We should encourage CMR because the fear of using dobutamine, fear of giving a stress in already jeopardized myocardium is always there. Suppose the patient is having ejection fraction 25-30%, and giving dobutamine and doing a peak stress, sometime some patient may land up in the LVF and leading to VT and getting shock. So I think we should start using more and more MRI as per the guideline recommendation, because once we will start using, our radiologists will be more accustomed.
We have to refer the patient to the radiologist, and radiologists should also be trained in that manner.
Only 3 Tesla MRI will be helpful in.
Will be helpful.
Thank you, sir, for nice presentation.
Thank you.
So the next talk is devices in heart failure, when to consider, and it has to be delivered by Dr. Vikas Agrawal, a dynamic and young professor of cardiology, IMS PHU. Dr. Vikas Agrawal, please.
Yeah. Good afternoon, everyone. Am I audible?
Yeah, you are audible.
So I'll just share my screen. Is my screen visible? No, no.
No, slides are not coming. बदल दो ना चेयरपर्सन बदल दो इसके बाद
Just give me a moment. I will just. Somebody has to stop sharing, I think.
बॉस आप शेयर करिए स्क्रीन, आप करिए, अभी कोई शेयर नहीं कर रहा, आप ही का दिख रहा है फ्री।
Sure.
पीपीटी ओपन करके तब शेयर करिए बॉस।
Accessibility कुछ प्रॉब्लम दिखा रहा है।
एप्पल का लैपटॉप है क्या बॉस?
हाँ हाँ। एक मिनट।
सर मैं उसमें आपके एनीडेक्स
आदि एक मिनट करो
सर।
हाँ।
आपके लैपटॉप में एनीडेक्स है?
नहीं, तुम्हारा पासवर्ड क्या है?
कौन सा? लिखो।
सर अगर मैसेज आ रहा है कुछ परमिशन का, तो आप मेरे को एनीडेक्स का पासवर्ड दीजिए, मैं आपका कर देता हूँ यहाँ से। वॉइस को अनम्यूट करिए सर, आपकी आवाज नहीं आ रही।
एक काम मैं ना दूसरे लैपटॉप से करता हूँ, हमको एक मिनट दे दीजिए बस।
ओके ओके ओके।
हाँ।
Hello, Vikas boss.
Yeah, I'm here. Just I'm just sharing my screen now.
ठीक है
अरे अभी
now it is visible. बस दिखाई पड़ रहा है सही है अब आवाज नहीं आ
उन्होंने अनम्यूट
हेलो या
हाँ दिखाई पड़ रहा है बस ठीक है ओके
audible. I am audible.
Audible.
Yeah. Thank you so much for waiting. Actually, I was stuck in that laptop. Thank you, Dr. Alok, for inviting me, and it's a pleasure to be in this Heart India Conclave. And congratulations to Dr. Alok for conducting it so successfully throughout the year and every year. And so the topic given to me is devices in heart failure. What is the evidence? And as we all know, heart failure is a important condition, and we have a lot of patients having heart failure. And the management of heart failure and the advancements in the management of heart failure have, over the past few years have been pretty exciting, and with a lot of new developments, and we have a host new of drugs that have become available for the last few years, and that have changed the paradigm of treatment of heart failure, especially with the advent of ARNI and SGLT2 inhibitors. And before I go further, I think we should understand that medical therapy is the cornerstone of therapy in management of patients of heart failure, and devices do play a role. And somebody who still stays symptomatic after on medical therapy would be the perfect person to go in for a device therapy. So I would like to talk about the established device therapies, and these include the AICD and the CRT and the newer devices that we have now, which I'll be talking in subsequently. So first, I'll be focusing on the established device therapies that we have for the management of heart failure, and one of them that we predominantly we already know is the implantable cardioverter defibrillator, or what we call as the ICD devices. And the ICDs are have a function of protecting a patient from death from a ventricular tachyarrhythmia, and this is done by delivering a shock or by the use of anti-tachycardia pacing. And this is basically, the device is programmed to protect the patient from from death from these tachyarrhythmia events, whether it is a VT or a VF. So the use of ICDs is pretty established in patients who already have these kind of episodes, and this is what we call a secondary prevention. So the recommendations are, from various trials that have shown that they prolong survival in patients who require ICD and for secondary prevention. And so the class 1A recommendation with different guidelines, which is undebatable, is in patients who have a documented VT or a VF, a VT which is hemodynamically not tolerated, and do not have reversible causes of or within 48 hours of myocardial infarction, and have a reasonable expectation of survival with a good functional status of more than 1 year. So this would be the perfect candidate to receive an ICD, and this is a class 1A indication for implantation of a ICD in a patient for with heart failure. Regarding primary prevention, and ICDs are also used for primary prevention, and primary prevention is also important. And there is a lot of data to suggest that ICDs are equally important in patients who have heart failure and who have LV dysfunction, and these ICDs would help in these patients. And there are a lot of trials, and the trials, if we divide them into two categories, patients having heart failure caused by ischemic heart disease and heart failure not caused by ischemic heart disease. Patients in which heart failure is caused by ischemic heart disease, the two most important trial were the MADID-2 trial and the SCD-HEF trial, which showed that these ICD devices do prolong survival in these patients by preventing sudden cardiac death, and they are a class 1 recommendation based on this two trials. And the meta-analysis also showed that there was an overall around 24% reduction in mortality or all-cause mortality in patients of ischemic heart disease having heart failure and LV dysfunction. MADID-2 trial enrolled patients, post-MI patients, class 1 to class 3 patients, and SCD-HEF trial enrolled patients who were class 2 to class 3 LV dysfunction of EF less than 30% in MADID-2 and less than 35% in SCD-HEF. So this is quite a concrete evidence that we have in patients having heart failure caused by ischemic heart disease. On the other hand, patients having heart failure not caused by ischemic heart disease, these are basically patients of dilated cardiomyopathy. The most evidence that comes from is the SCD-HEF trial, and one of the trials after the SCD-HEF trials was the definite trial. And the amount of evidence that we have in this group of patients is plus minus, because SCD-HEF trial showed a significant benefit of ICD implantation in patients who had heart failure not caused by ischemic heart disease. But the definite trial did not show reduction in all-cause mortality, although it reduced the sudden cardiac death events. So for primary prevention, we do have evidence in ischemic heart disease, but in non-ischemic heart disease, there is doubt created by a few trials. This is and one of the reasons what they say is that the mortality is high in patients of ischemic heart disease as opposed to patients having non-ischemic heart disease. And this is a graph from the SCD-HEF trial where it showed that patients, the relative benefit of ICD therapy is despite a lower mortality in patients of non-ischemic cardiomyopathy, the relative benefit of ICD therapy in patients of non-ischemic cardiomyopathy is equivalent as ischemic heart disease. So maybe there is an overall mortality is lower in non-ischemic cardiomyopathy, but the ICD does benefit these patients to an equivalent amount as compared to the ischemic cardiomyopathy. So the SCD-HEF trial showed that ICD is beneficial even in non-ischemic cardiomyopathy patients. So these are the guidelines regarding the ICD implantation, patients having left LV dysfunction, ischemic heart disease, class 1, NYHA class 2 to 3, class 1 with level of evidence A. NYHA class 1 patients, ESC does not recommend, but US guidelines recommend it as a class 1A evidence. The important thing here is time after MI, and it should most of the MADID-2 trial showed that it should be not just after MI, but at least 6 weeks or 40 days after post-MI that the ICD should be implanted. Before that, there is increase in mortality. For non-ischemic heart failure, class 1, but level of evidence here is class B, and these are a few years older guidelines which recommend ICD in both ischemic heart failure and non-ischemic heart failure. But the confusion for non-ischemic heart failure came with the publication of the Danish trial. The Danish trial was in patients on non-ischemic dilated cardiomyopathy, and these were basically 1,000 plus patients who were randomized to ICD or usual clinical care, and around 58% of patients uh, uh, received CRT device in both the arms. So it was basically a lot to do with CRT versus CRT plus ICD comparison according to this trial. So the Danish trial was negative trial. There was no mortality benefit of ICD on top of optimal medical therapy, though it reduced SCD reduction by 50%. So this was a trial that shook the faith in ICD in patients who had non-ischemic cardiomyopathy. But a sub-study of the Danish trial showed that there was still a mortality benefit of 36% of ICD in patients less than 68 years of age. So younger patients, not less than 70 years, did benefit in the Danish trial also. So people went out to find out why people in the Danish trial did not benefit, and earlier in the SCD-HEF trials did benefit in non-ischemic cardiomyopathy, and they tried to find out different reasons. And one of the reasons that they proposed was that in the Danish trial, medical therapy was pretty better optimized as compared to the previous trial that was 10 years prior to the Danish trial. So on ACE inhibitors, beta blockers, MRAs, around 90% of patients received ACE inhibitors, beta blockers, and around 60% received MRAs. So medical therapy was better optimized. More of the patients were on optimized medical therapy. And maybe this was the reason that the Danish trial showed very low SCD rate of around 1.5% per year, and only 35% of all deaths were sudden in the Danish trial. And as we can see this graph here, these are basically trials of the medical therapy in heart failure trials, which have shown that over the years, as we have improved our medical therapy in patients of heart failure, the SCD rates have come down drastically in all patients of heart failure. So due to the medical therapy improvement, more and more SCD events have come down in patients. So maybe this is the reason why the latest trial in non-ischemic cardiomyopathy did not show a significant benefit in all-cause mortality. So how do we go about from here? And there was benefit in earlier ICD trials, but negative results in the Danish. So how do we go about? So looking at the guidelines and how to select patients who would benefit the most from ICD is important. And here risk stratification comes into picture, and a lot of people have recommended different risk stratification algorithms, which include clinical markers, electrophysiological markers, and imaging markers. And one of the clinical markers that they propose is the MADIT2 risk score, where they included 5 parameters to find out the risk that the patient had to calculate the risk and then calculate the benefit that he would derive from implantation of his ICD therapy. And what they found out that patients who had very high risk, and very high risk are patients who had a lot of comorbidities and end-stage renal dysfunction. These patients did not benefit by implantation of a ICD. And other group of patients like intermediate risk patients who had one risk factor did benefit from ICD therapy, and lower risk patients did not benefit from ICD therapy. So the target of the ICD could be, to derive maximum benefit would be the intermediate risk patients having one risk factor. The risk factors they included was NYHA class, age, blood urea nitrogen, QRS duration, and I think one was atrial fibrillation. So looking at these risk factors, maybe intermediate risk patients would be the best to derive benefit from ICD therapy. Similarly, they proposed the Seattle heart failure model, where they found that patients who had intermediate to low risk benefited from the ICD therapy, and not patients who had very high risk. So these clinical parameters could be taken into account. Similarly, electrophysiological markers, and one of the markers that is coming up into picture is imaging marker, and they have started using cardiac MR to quantify the scar that is there in the myocardium, and maybe a patient having more burden of scar would derive more benefit with ICD therapy. And one of the trials showed that mid mid-myocardial scar on cardiac MR, which was detected by late gadolinium enhancement, could be a predictor of increased sudden cardiac death, and these are the patients. So a risk stratification approach is a better way to to find out patients, and individualized approach is one that people are proposing now for ICD implantation in patients of heart failure. So this is algorithm. I have already talked about it. What kind of ICD is advisable? A single chamber ICD is the one that most of the patients require. Patients who have sinus node disease and require atrial pacing, a dual chamber ICD could be the one that could be required in those patients. Coming to the next is cardiac resynchronization therapy, and as we all know, cardiac resynchronization therapy is established therapy in heart failure, and various trials have shown that CRT does reduce mortality in patients of heart failure, and the most important trials are the companion trial and the CARE-HF trial. These are patients of heart failure with less than 35% ejection fraction, a QRS duration which is more than 120 milliseconds, and on optimal medical therapy. And it was shown that mortality was reduced in the tune of 36% in both the trials. So CRT after that was given a class 1 indication in patients who had a wide QRS and had heart failure. And these were basically class 3 patients. Most of the patients in companion and CARE-HF were class 3 patients, but subsequently 2 trials, one is reverse trial and the MADIT CRT trial, also showed consistent benefit of CRT for patients with LVBB in class 2. So class 2 patients were also included to benefit from a CRT, cardiac resynchronization therapy. There has been debate about imaging for selection of patients. Imaging does not play a role for selection of patients for cardiac resynchronization therapy, and the absence of pre-implant mechanical desynchrony should not defer the implantation of a CRT device. Somebody who has indication according to the ECG criteria and LV dysfunction on echocardiogram should receive a CRT. Imaging may help to determine whether the choice is between a CRT-P or a CRT-D, and imaging can help to detect disease progression and guide auxiliary therapy, but none of the trials mandating imaging for selection of patients found benefit for implantation of a CRT. There is controversy about benefits of CRT in ischemic versus non-ischemic cardiomyopathy, but most of the trials have shown, whether we see the companion, the CARE-HF, MADIT CRT, or the RAFT trial, when we look at the population of ischemic versus non-ischemic, the benefit was there in both the ischemic and the non-ischemic population. And in ischemic cardiomyopathy, though the relative benefit was lower, but the absolute benefit was even more as compared to non-ischemic cardiomyopathy. So the absolute benefit was much higher, and the number needed to treat was much lower for ischemic cardiomyopathy. So it has benefits both in ischemic as well as non-ischemic cardiomyopathy. A lot of times we have to decide whether the person requires a CRT or a CRT-D, and this has to be individualized for a patient. And this is an algorithm from the HRS guidelines that they have, which is very useful to decide whether the patient requires a CRT-P or a CRT-D. And what they have recommended that in the green zone are the patients who have a preference for CRT-D. In the red zone, these are the patients who are only require a CRT-P, and they would benefit from a CRT-P only. And what they said that secondary prevention favors a CRT-D, LVBB morphology favors a CRT-P, and IVCD favors CRT-D. Mechanical dysynchrony favors CRT-P. Comorbidity, somebody having more comorbidity should be only given a CRT-P. Genetic mutations for sudden cardiac death should favor a CRT-D, and more of scars in the myocardium should favor a CRT-D. So it has to be individualized whether a patient would be more suited for a CRT-P or a CRT-D. Then is the controversy of finally the response to CRT, and people have been saying that 1/3 of the recipients of a CRT are non-responders, and that is a lot of apprehension that people have whether he would be falling in a responder or a non-responder group. And what the current scenario is that people have started saying that it's not only the response that is important. Apart from responders and non-responders, there are patients who are non-progressors, and as we all know that heart failure is a progressive malignant disease which has a downhill course, and if the CRT is able to stabilize his disease and keep him symptomatically better, and that the terminology that they give is these patients fall as a non-progressor, even is even equivalent to a responder after implantation of a CRT. So if you are able to achieve this state, a non-progressor state with a CRT, it is even better. It is equivalent to a responder. So nowadays it is said that a non-responder may be a non-progressor, which is good after implanting of a CRT. So what they have, what they are talking about is that disease modification instead of response should be the top criteria after a CRT implantation, and maybe you are able to make a patient from to if you a super responder, a responder with full remission. Partial remission is also good, and some patients would definitely have disease progression. So what CRT would do is halt the natural history of heart failure, and also give response of full remission to some patients. So it's not non-response that is now being talked about, but it's remission and full remission and retardation of disease progression after implantation of a CRT that is being talked about. The other thing is that what about conduction system pacing? Is it a substitute for CRT indicated patients? And still we have no data to suggest that, and still conduction system pacing, whether it is his pacing or LBB pacing, should be able to show at least equal benefit in terms of morbidity and mortality endpoints, and has to be as safe as in RCTs to be implemented in clinical practice as an alternative to CRT. So still CRT has its place and CSP cannot substitute it. So these are the guidelines. Somebody with LVB morphology with a QRS deviation of 150 or more, class 1A indication, LBB with 130 to 149, class 1B. And for non-LBB, the recommendation level is lower because of the evidence not being that great, with non-LBB 2A with QRS more than 150 and 130 to 49 2B. Then coming to the next device, and this is an exciting device that is coming up in a big way in heart failure. It's basically devices to treat mitral regurgitation, and this is a mitra clip system. It is basically end-to-end repair of the mitral valve, and these are clips that are implanted into the mitral valve to reduce the severity of mitral regurgitation. And generally patients of heart failure have secondary MR. So secondary MR, the mechanism is basically a dilated left ventricle, the papillary muscle displacement and leaflet tethering that causes severe MR in these patients. And severe MR is graded by different indices that we detect on echocardiogram, whether it is a regurgitant volume or effective regurgitant orifice. And somebody who has a severe MR or a moderately severe MR with heart failure has been shown to have worse prognosis as opposed to somebody not having MR. So the most important trial that tested this, that treating MR in these patients by by mitra clip or reducing the mitral regurgitation, does it improve survival? And the COAP trial was the one to do this. They included patients of class 3 to class 4 MR. Symptoms were class 2 to class 4A. They were on maximal tolerated doses of guideline directed medical therapy. One of the important inclusion criteria was LV ejection fraction of 20 to 50%. The end systolic diameter that was included in this trial was less than 7 centimeter. PAST was less than 70. None of the patients had right-sided heart failure or moderate to severe RV dysfunction. That was an exclusion criteria. TR requiring surgery or transcatheter intervention was an exclusion criteria. And the most important thing was that the mitral valve was clippable. So these were the patients that were included in the COAP trial. 24 months results showed a significant reduction in heart failure hospitalizations. All-cause mortality was significantly lower in patients who received the mitra clip with a p-value of significant p-value and a hazard ratio of 0.62. So this was one therapy that showed mortality benefit in patients of heart failure. And when they extrapolated the number needed to treat to prevent one death, it came out to be 5, as opposed to this is a very different slide which showed that different drugs that we have a number needed to treat of 30 to 40, but mitraclip had number needed to treat was 5, which is so significant. But again, we should know that the inclusion criteria was pretty stringent, and these were very selective patients who would qualify to be included in this trial. The extended follow-up at 36 months, even more significant benefit, that curves kept on diverging, and there was even more significant benefit that was seen with mitraclip. But one of the other trials of mitraclip, the MITRA-FR trial that was conducted in Europe, did not show any mortality benefit, and this was before the COAPT trial. So people went out to say why differences, baseline characteristics, maybe the baseline characteristics were the reason that in patients in MITRA-FR did not derive benefit, but in the COAPT trial derived extensive benefits with the use of mitraclip. And the reason what they said that the baseline characteristics in the MITRA-FR trial were patients did not have that severe MR in the MITRA-FR trial, and the LV and diastolic volume index was much higher as compared to the COAPT trial. So the LVs were more bad as compared to the COAPT trial. So maybe this was the reason that the COAPT trial patients derived benefit. And so here comes they coined a new term which we called as the disproportionate MR, and the patients who have a disproportionate MR are the ones who would benefit from a mitraclip. COAPT also had a more stringent criteria for guideline-directed medical therapy before enrollment. They excluded patients of severe TR and right-side heart failure. And COAPT also included patients with more severe MR and less LV dysfunction. So these are the patients who should be targeted to benefit from a mitraclip. And these patients are the ones who have disproportionate MR, means the LV is not that dilated, but the MR is severe, and these are the ones who would benefit from a mitraclip. So this is a graph that showed the patients who would benefit from a mitraclip, patients having LV dysfunction, but LV and systolic diameter should be less than 70 millimeters to make the mitraclip useful according to the latest guidelines. The guidelines have implemented the same thing. They have given a class 2A recommendation for Planck's catheter S2S mitral valve repair according to the COAPT trial, and these are the patients who are currently being judged suitable for mitraclip repair. Other devices to treat mitral regurgitation or tricuspid regurgitation. One is the Carilion mitral contour system that is under investigation. This is basically an annuloplasty system which is implanted into the coronary sinus, and this basically aligns the coronary sinus, the mitral annulus, to make it more nearer to each other, and this reduces the MR. So this is also a percutaneous device that is under trials. Then transcatheter mitral valve replacement is coming up in a big way. A lot of trials. This is done transapically, and it is also found in patients of heart failure. TriClip is basically like the mitraclip. This is implanted into the tricuspid valve. The tricuspid valve, the right-sided valve in patients of severe TR and RV dysfunction, and has been found to be helpful in patients of heart failure. Next, these are the main therapies that I would be talking about. There are a lot of other therapies that are coming up in a big way, and one of them is, as we all know, there is autonomic dysfunction in patients of heart failure, and autonomic modulation would be one of the ways in which heart failure patients could benefit. And one of the therapies that is coming up in a big way is baroreflex activation therapy. And as we all know, the carotid sinus and the aortic sinus are the ones that regulate the sympathetic and the parasympathetic outflow. And what is a device is implanted into the carotid baroreceptor system, and this basically through the brain stem basically augments the parasympathetic activity and decreases the sympathetic activity, and thereby decreases the sympathetic activity and brings about benefit in these patients of heart failure. So baroreflex activation therapy has also received FDA approval for therapy in patients of heart failure, and few trials have shown that they improve quality of life, they improve exercise capacity, and they reduce NT-proBNP. So this could be exciting therapy in the future in patients of heart failure. Then vagus nerve stimulation. This is basically pulse generator that is implanted into the pectoral in the pectoral region, and a standard pacemaker lead is implanted into the right ventricle, and a stimulation lead is given into the vagus nerve to basically increase the parasympathetic activity and decrease the sympathetic activity. And trials have shown that they improve the symptoms as well as LV and systolic volume index in patients of heart failure. So this could be one of the therapies. Then the other thing is electrophysiological modulation and electrophysiological modulation. One of the therapies that is coming up is cardiac contractility modulation, and this is basically a pacemaker like device that is implanted into the like a pacemaker with leads going into the RV apex and RA. And basically what it does, it gives different signals which is applied during the absolute refractory period of the RV septum via standard pacing leads. So it does not give contractility, but it basically gives a biphasic long duration high voltage electrical signal to the RV septum during the absolute refractory period. And this brings about structural and functional changes in the myocardium, and it becomes more efficient with time. And trials have shown that this type of therapy brings about biological effects seen remotely over time, and it improves peak VO2, reduces hospitalization, and have different effects. So this is one therapy that is coming up in a big way in patients of heart failure. Respiratory modulation, patients of central sleep apnea, very much common in patients of heart failure. And these are basically patients, electrode is given into the diaphragm, which basically increases its respiratory capacity and respiratory, and in a way improve these patients by basically phrenic nerve stimulation. This is especially in patients who have central sleep apnea with heart failure, where this therapy has been found useful. Then we have structural interventions. Structural interventions basically is by interatrial shunting. There are different devices which basically create a left to right shunt as we create an ASD. And basically patients who have increased pulmonary capillary wedge pressure, especially patients of heart failure with preserved ejection fraction, these devices basically create a shunt from left to right, decongest the left atrium, decrease the pulmonary capillary wedge pressure, and bring about symptomatic benefit. And a lot of trials have shown that they are helpful for reduction of symptoms, reduction of pulmonary capillary wedge pressure, and improvement in these patients. Most of the trials until now have been done in heart failure with preserved ejection fraction, but a few studies are ongoing in heart failure with reduced ejection fraction also. So this is regarding the latest therapies that I've talked about. The FDA has approved a few therapies: the transcatheter H2S mitral valve repair, the TR, what we call the COAP trial, and the MitraClip. The cardiac contractility modulation CCM device, they have given FDA approval, and these are indicated in patients of QRS duration less than 130, LV ejection fraction of 25 to 45%, currently contraindicated with long-standing or permanent atrial fibrillation. Baroreflex activation therapy, LV ejection fraction of less than 35%, but exclude patients with a guideline indication for cardiac resynchronization therapy. Phrenic nerve stimulation, moderate to severe central sleep apnea, independent of heart failure. So these are ongoing. Actually, FDA has expedited device therapy for heart failure approvals, and they have come up with a different program where the devices are being the lot of around 300 devices are into into trials for different, and they are expediting clinical use of these devices for heart failure. So I think that is all. One of the devices that I didn't talk about, one is an implantable pulmonary artery. This is a device that monitors the pulmonary artery pressure and how this helps in monitoring patients of heart failure. This is basically a leadless device that is implanted into the pulmonary artery distally. This basically gives the patient information about the pulmonary capillary wedge pressure, and the treatment is given looking at the pulmonary capillary wedge pressure. And one of the trials, the name of the device is CardioMEMS device. Basically, it's monitoring the pulmonary capillary wedge pressure in patients of heart failure for treatment. And the CHAMPION trial showed that monitoring this and treating these patients reduces heart failure hospitalization. So for monitoring of therapy, also exciting times ahead for management of patients of heart failure. Thank you.
Thank you, Dr. Vikas, for nice presentation and detailed presentation. So as there is no question in chat box, so I will start with the next session. Okay. There's one question by Professor Sanjay Kumar.
Thank you, Alok, for because nice presentation. I just wanted to ask you one question about related to the CRT. Compared to CRT and CRT D and P, what is the median survival benefit in these patients, and what is the expectation of improvement of ejection fraction in this patient? And another question is also, what kind of quality of life do they have? Can they like exercise and other normal activities of life, the benefit on CRT?
Yeah, so actually that graph that I showed, the response to CRT varies, and depending upon the kind of patient that you include to be implanted a CRT, and the response can vary from a super responder. A super responder is one where the LV dysfunction clearly normalizes with after implantation of a CRT, and it becomes normal. It becomes 55-60%. These are super responders. Then there are partial responders whose LV function increases by 10 to 15%, and they are categorized as responders. There are some that do not respond to the extent that the LV function improves drastically or maybe by 5 percentage points, but they stabilize after implantation of a CRT. Their clinical parameters improve, the NYHA class improve, and they remain stable after implantation of a CRT. And that is a group of patients that are not now being called as non-progressors, or being stable after CRT implantation. What they say is that around 1/3 of patients are non-responders to CRT, but that is something that is even lower. A lot of times CRT has different aspects to its management. Only implantation is not only important, but after implantation, programming of CRT, giving it optimization of CRT by different parameters is also important. A lot of times by proper optimization of the CRT parameters, a non-responder becomes a responder. So it's a continuous optimization that should take place after implantation of a CRT to judge how CRT is affecting. But the trials have shown that it does. A lot of patients, properly selected patients, do derive a significant benefit with CRT.